Um, we'll get the recording started. Thank you, Andy. And with our echo, for if you are new today, if you're comfortable, we ask that you do turn your camera on. If not, if you're eating lunch or whatever, don't feel obligated. But we also encourage you to ask any questions. So at the end of Dr. Grove's presentations, she will open the floor for any questions. And you can do that either you can use in the reactions, you can use the raise your hand feature, or feel free to take yourself off of mute to ask your question directly. And so before we get started, I'm going to ask Andy to pull something up that we wanted to share with you, because many of you there's been a lot in the media over the last couple of years related to colorectal cancer diagnosis happening in people younger than age 45. A couple of years ago, the actor Chadwick Boseman passed away from colorectal cancer in his early 40s. And I wanted to share with you some data that we have. The National Cancer Institute has a section that they call Cancer Map Stories, where they've looked at the data from the Surveillance Epidemiology and Results Program that the cancer registries report to. And they looked at that data over the last 20 years and have been able to create some maps. And so for this map story on young colorectal cancer, it will, and Andy will put the link for this in the chat, it will provide you with the information about risk factors, but we wanted to get in here and share a little bit about incidence. And so this is going back this data will go all the way back to 2011. So 2001, excuse me, the 2011 to 2015, this is showing for colorectal cancer incidence between people within the ages of 20 to 49. So this is showing in the entire the entire United States. And so of course you can see that West Virginia is highlighted in red. So our age-adjusted incidence is one of the highest. And I'm going to ask Andy to slowly scroll through the rest of this, because this is going to give you some of the historical context of this. So when they looked at the data from 2001 to 2005, there really was only a handful of states that were starting to see an increase in young onset colorectal cancer. West Virginia and Kentucky, unfortunately, we're always, duking it out for, who is ranking number one on some of these things. But even in that time period, our incidence rate and Kentucky's incidence rate was still considered moderate. When you look at the next 5-year cohort of looking at data from, and I'll ask Andy to scroll down, from 2006 to 2007, you can see that those numbers are shifting. So we are now at the much higher range within the age incidence rate, and there are additional states that are starting to join that cohort. And then I'll have Andy scroll down and we can look at the 2011 to 2015. And here you can see, so a lot of it is happening in a lot of these, southern, southeastern, some of the states within the Appalachian region. And then, okay, and then the rest of this is death rate. So Andy can exit out of that. But as I said, she'll put the link to this in the chat if you'd like to take a look at that later. But as you can see, that really for the past 20 years, West Virginia has been leading the nation in early age onset colorectal cancer diagnosis. And so we want to welcome our featured speaker today, Dr. Emily Groves. She is with Surgical Oncology at WVU Medicine. And Dr. Groves, welcome, and thank you for presenting to us today.
Thanks for having me, and thanks for showing us that data to kind of put it in perspective. Can you guys hear me okay? I am going to share hopefully just one screen. And okay. So I've put together this presentation about young onset colorectal cancer at your request. And it's interesting. I've been here at WVU for 5 years, and I've even noticed in my practice a fairly rapid increase in seeing young onset colorectal cancer. My first couple years here, it was relatively rare, and now it's, I have a handful to a dozen patients that are under 45, and certainly plenty under 50, even patients in their 30s. And so this is a growing problem. West Virginia is kind of leading the nation in this problem and in colorectal cancer rates in general, even in a later onset population. So I think it's really important that we discuss kind of ways to mitigate this as we move through. Trying to make this better. So I took the learning objectives that you listed and added a couple, just defining the young onset colorectal cancer cohort, discussing general questions, mostly discussing cancer prevention, early detection, treatment, and survivorship. Also identifying best practices and other things that may impact the overall outcome and treatment of cancer, and then explore primarily the benefits of early detection. As I see, that's kind of where this group could really show its muscle here is in the space of early detection for the patients that come in, and how that impacts their quality of life and their cancer recovery and survivorship. So what is it? It's age less than 50. There's actually not a total consensus on what is young onset colorectal cancer. Initially, it was described as less than 55, then less than 50. Now some papers are describing it as less than 45, but I settled on this round number as this is kind of where most of the data is centered, is in the under 50 population. The incidence in this population has increased 51% since 1994, and it's been a gradual increase each and every year, slow and steady till we've gotten to this point here, and it's not really showing any signs of slowing down. To that tune, 11% of colon cancer diagnoses and 18% of rectal cancer diagnoses in the U.S. are in this young cohort. And until recently, screening colonoscopy didn't start until 50. So we're missing, even if we had 100% compliance with screening colonoscopy, we'd be missing nearly 20% of the rectal cancers. So I think it's important to discuss not only surveillance, which is, or not only screening, which has gotten so much better over time, that the overall incidence and the incidence of late onset colorectal cancer is actually diminishing thanks to how good we are at screening and how good we're getting, but also move into this early detection space, which is really important for our younger patients who don't meet the criteria for screening colonoscopy based on age. By 2030, colon cancer incidence is expected to double, and rectal cancer incidence is expected to quadruple in this age group. So like I said, this isn't showing any signs of slowing down. And I think a lot of us think, well, it must be due to a lot of genetic conditions, but actually only up to 20% of patients are expressing these FAP, Lynch, familial colorectal cancer syndromes that are clearly genetic related, and most of these are sporadic and just happening not with any familial link. So I think it's important not to just write this off as a familial issue. Because young colorectal cancer patients tend not to be diagnosed at the earliest stages, it does turn out to be some of the deadliest cancers for this age group. So that's another reason to beware and be aware of this growing problem. So I thought this was a really good article that kind of set the scene. It's from 2014. I think, most of the articles surrounding this discussion of young onset colorectal cancer didn't start to come about until the mid 2000s, like 2004, 2005. And finally in the mid 2010s, really started to gain traction, where people were noticing that this is a countrywide phenomenon, a worldwide phenomenon. And we've got to do something about it. So this was the call to action saying that, while these cancer rates are falling in older folks very slowly, the young onset cancers are on the rise. They're presenting in advanced stages. Part of that is that the patients themselves are ignoring the symptoms or are too busy to notice the symptoms. And then part of it is that practitioners often rate these symptoms off as normal processes and not true pathology. Young onset colorectal cancer patients are more likely to occur in the distal colon or rectum, be poorly differentiated, have mucinous and signet ring cell features, which obviously make it more generally aggressive. However, stage-specific survival rates in patients with young onset colorectal cancer are actually comparable to that of patients with later onset cancer. So if they present with stage 3, it's going to behave like stage 3, even though they have some of these more aggressive pathologic signs like signet ring cells and poor differentiation. They can tolerate therapy very well, and so their outcomes are all similar to later onset patients that present with stage 2, 3, or 4 cancers. So that's encouraging and more fuel to our fire that the earlier we can get these diagnosed, the better the outcome's going to be. So what are the risk factors? So these are risk factors that have been kind of hammered into us over the years regarding colorectal cancer in general. Physical inactivity, obesity, smoking, excess alcohol intake, red and processed meats, low fiber diet. I enjoyed this article out of Japan last year, 2 years ago, that actually showed a direct correlation between time spent in front of a television and mortality rates from colorectal cancer. And these were adjusted. They looked at thousands and thousands of patients. If you spent more than 3 hours watching TV, you were more likely to die of colorectal cancer. And that was adjusted for fitness, BMI, activity level, and everything. So it's literally isolated increased risk factor of watching television, which I found fascinating. Despite all this, I think a lot of this is overkill. I think we know that these things are bad for us that are listed on the slide, but we actually have no real data connecting the role of all of these in the young colorectal cancer patient. Because we do have so many patients that don't fall into these categories. And I think one of the pitfalls is that, if we see a patient that doesn't have these things and maybe has rectal bleeding, all of a sudden we're less likely to get that patient a colonoscopy, when in reality that patient would need screening as well. So while we've found these risk factors and they do increase risk very slightly, if you think about it, red and processed meats, if your overall colorectal cancer risk in your life is 5%, red and processed meats, if you eat that daily, so daily pepperoni roll like a good West Virginian should, you're going to increase your colorectal cancer rates by 20%, which sounds like a ton, but you're taking your absolute risk from 5% to 6%. It's not negligible, but it's something that, like, the randomness of the universe can also account for too. So while we keep these risk factors in mind, we don't hang our hats on here, and this is why. Does anybody know who the baseball player is? You can put it in the chat. I'll probably jump the gun because I talk too fast anyway. This is Trey Mancini. He's a very talented baseball player. He plays for the Baltimore Orioles. At 27 years old, he showed up to spring training in 2020 a little tired. Wasn't getting as much out of his workouts. Just felt that something wasn't right. But that was pretty much it, just fatigue. Told the team doctors. They did some labs, found out that he was mildly anemic, nothing too terribly out of the ordinary. Got him a colonoscopy, and it turned out he had a colon cancer at age 27. And that's, a professional athlete keeping himself in good shape, probably not eating his pepperoni rolls every day like me, and really taking good care of himself. So he got an appropriate colonoscopy, and even, as on top of things as he and the team doctors were, it was already stage 3. So he required chemotherapy, missed the entire 2020 season, came back in 2021, and is like, a pillar of survivorship and somebody for these young cancer patients to look up to, because he came back and had a pretty nice little batting average the very next year, a 758 on base plus slugging, pretty impressive. So I think he's really what our young cancer patients are capable of in terms of survivorship. And as long as we get them diagnosed early, this is kind of a testament of what we could see in our young patients. So what we can do as providers is, most importantly, just be an advocate for proper screening. As most of us know, the screening recommendations were changed from 50 years to 45 years, kind of gradually by various societies, but now we can pretty much all agree on it. So 45 years old, make sure you advocate for patients to do that. Then anyone with a significant family history should be identified, and the screening recommendations should be followed. I think, one opportunity for this is just right in their intake as they're coming to see you and they're filling out the family history paperwork, and we'll go through kind of what the recommendations are based on family history shortly. And then finally, any symptoms of colorectal cancer should be identified and evaluated early. I think patients are very quick to ignore their colorectal cancer symptoms. And we as practitioners actually have to kind of draw that out of them and say, no, that actually could be serious. And we do need to evaluate this, because young people don't like to talk about their poop, it turns out, for the most part. And so we often have to draw that out of them, and then we have to be the ones to advocate and convince them to get a colonoscopy that they probably don't want to get. And that can be really challenging, and sometimes you have to be persistent. I think family history is one that is very interesting, because colorectal cancer is unique in that we have pretty clear recommendations in terms of screening colonoscopy for patients with first-degree relatives. So if they're doing their intake form and you see a lot of colorectal cancer in clusters on one side of the family, or if you see a first-degree relative had colorectal cancer, screening colonoscopy should be done every 5 years, and that should start at age 45 or 10 years before the age of the relative at their time of diagnosis. So if mom was diagnosed with colon cancer at 54, then the screening process should start at 44 for the child, or the brother or the sister. So first-degree relatives, 10 years younger than the age of diagnosis of the original patient. And that you could set up right off the bat as soon as they do their intake form. Just have it in your plan, set a date so the patient doesn't forget, write a letter, do whatever you got to do. That'll help take care of that, hopefully 10 to 20% that are genetic related. However, I think probably the biggest room for improvement that I see in my practice is some of these being aggressive about evaluating some of these red flags in patients. One of the studies I looked at said that 58% of patients had to see 2 different practitioners before they were referred for colonoscopy. And that's because these symptoms are often very much downplayed by the patient. They may say, oh, I had a little bit of blood in my stool, but maybe I was lifting, or maybe I was really stressed and I have diarrhea and sometimes it happens, or it seems like, because again, no one wants to have a colonoscopy, these symptoms are pretty quick to be forgotten. But blood in the stool should always be evaluated. Even if you suspect hemorrhoids, it doesn't hurt to rule out, more sinister causes, and then I can take care of the hemorrhoids too. Any iron deficiency anemia that gets flagged on lab should be evaluated with colonoscopy as well. Caliber changes should be taken seriously. A lot of patients get told they have IBS, but without a colonoscopy to rule out other things, we really don't know that that's the case. And then abdominal pain and unexplained weight loss are kind of the last 2 symptoms on the list. Those are a little more obvious. But I'd say probably the ones that I see the most where the diagnoses were missed is blood in stool. It gets blamed on a hemorrhoid, or an iron deficiency anemia that doesn't quite get worked up, or the stool caliber changes that they get chalked up to IBS or lactose intolerance or something like that. I know that it's hard to get people a colonoscopy, at least here at Ruby, but just encourage the scheduling of that colonoscopy early if you see any of those signs. As far as how to work this into your workflow, you guys know better than I do how this works, but um, getting them on the family history screening, and then actually asking them about their stool, because a lot of people won't volunteer this information necessarily right off the bat, but maybe just a quick question about, do you ever see blood in your stool? So you get the answer yes. You convince them to do the colonoscopy. They show up, they get their colonoscopy done, and these are the types of lesions that get found. A and B are like apple core lesions. Kind of the classic description. The bottom two are more exophytic lesions. These require fairly deep biopsies for the diagnosis, but this would come back, adenocarcinoma of the colon or rectum. And that's how they would get that pathologic diagnosis. From there, anytime we do that, the next step is staging. So once you have your pathology, you stage the tumor. For colon cancer, we just get a CT chest, abdomen, pelvis, and a CEA. For rectal cancer, we get a CT chest, abdomen, pelvis, a pelvic MRI, and a CEA. So the carcinoembryogenic antigen is what we follow in terms of labs for both of these cohorts. It doesn't necessarily mean anything if it's non-detectable, but if it's high, it can be a good marker to follow throughout their therapy. Another thing that we're doing here at Ruby for most patients is that they're getting circulating tumor DNA. We're involving most people in our circulating tumor DNA study. It kind of acts as a CEA, but is a more reliable indicator of successful treatment therapies. If you can get rid of the circulating tumor DNA, then you know that you have it on the run. I could do whole talks on staging for colon and rectal cancer, but I don't think that part's as important as just early detection. Just briefly to hit on some of the points of treatment of colon cancer that your patients are going to have and have gone through. For colon cancer, the standard of care is generally to do surgery up front, and then if there are positive lymph nodes in the specimen, to do chemotherapy afterward. However, there was a trial that came out recently called Foxtrot, where if there are obvious lymph nodes, or if there's a compromised margin, meaning I don't think I can get the whole thing out surgically, we would give that patient chemotherapy first, do surgery, and then finish the chemotherapy on the back end. So that's why some of your patients may have started with chemo, some of them may have started with surgery. The treatment modality just depends on the tumor itself, how locally aggressive it is. And if it's stage 4, obviously we try to do chemotherapy first when that's safe, because that's what extends their survival. For rectal cancer, the whole paradigm has changed. I think, for most of us, we grew up with, for locally advanced rectal cancer, we did chemoradiation, surgery, followed by chemotherapy. That's what they did for, the last 20 years or so. In the last couple of years, we've changed the paradigm. These two schemes that you see in front of you are known as total neoadjuvant therapy. So you get all of your therapy up front, and your surgery is kind of the carrot at the end. This prevents people from falling off the chemotherapy bandwagon, because once they get their surgery, chemo's no fun. People were getting about 40% of their planned chemo when we did it after surgery, but we found that if we do it before surgery, they actually get much closer to 100% of the planned chemo. Depending upon how advanced the tumor is, you could get chemo up front, or you could get radiation up front, followed by chemotherapy. The endpoint of both of these would be surgery to remove the tumor. The other thing I just wanted to touch on that I think is going to be coming into everyone's practices soon, if you don't already have patients on this, is what's called watch and wait. This is revolutionary. This is something that we've kind of come up with in the last 5 years. This is all based on data originally out of Brazil. One doctor, Dr. Habergama, she decided that if we can treat anal cancer with chemo and radiation alone, maybe we can treat rectal cancer with chemo and radiation alone. She decided this because when she was looking at the specimens that they were taking out after doing this radiation, then chemo, then surgery, 25% of the specimens didn't have any cancer in them. So she got brave and thought, let's not take out the rectum. Let's, improve these patients' survivorship by letting them keep their organ. And so this is an organ preservation opportunity, whereby if we do the chemo radiation and then we do the chemotherapy, and then I look with my little colonoscopy and I see that the tumor on the left has turned into this white stellate scar on the right, there's an opportunity to actually leave the rectum in place. And I hate this name because watch and wait sounds so ominous, but watch and wait and see what happens with this tumor. We call this a complete clinical response. And then I would, every 3 months, do a scope and an MRI to observe this tumor bed, make sure that it doesn't recur. 25% of people that get put on a watch and wait strategy do recur. 75% of those people recur locally. So we still do our regular surveillance whole body scans with CT, chest, abdomen, pelvis, but the vast majority of patients are going to recur locally, at which point we would take out the rectum and they're kind of back where they would have been in the beginning, but at least we gave them a chance to live out their years with their rectum, which for young patients is often very important to them to avoid a stoma. So that's something that you'll probably see in your practices as patients come through. And I just wanted to make you aware that it's not that we forgot about the cancer. We're watching it carefully, but it's a new opportunity for patients to keep their rectum. And that kind of leads into the survivorship in the young patient. This is totally different, I think, in many ways, compared to survivorship in an older patient. Because often the young patient's very concerned about the potential for a stoma, whether it be permanent or temporary, versus occasionally older patients will say, well, I was incontinent anyway, doc, I love my stoma. Or, young patients are always quite concerned, and rightfully so, about their sexual function, versus some of my older patients are like, yeah, I wasn't using it anyway, kind of thing. So a lot of my discussions, with the patients that are younger, revolve around their post-treatment sexual function, fertility preservation prior to receiving any radiation or surgery, because in this cohort of patients that's 20 and 30, they may not be done having kids. And I want to make sure I have that discussion with all of them before we start doing surgery that would affect their pelvic nerves or their fecundity, or getting radiation, which would, obviously fibrose organs and make things a challenge in that way. And then finally, anyone with a colorectal cancer under the age of 50 gets a referral to genetics. If they get a hit, on their genes, their children and siblings also get referred to genetics as well. Patients are often, very concerned, obviously, for themselves, but then also they want the screening recommendations for their children. So we just go back to that first degree relative. 10 years prior to your diagnosis is when your children will be screened. The other part of survivorship in the young patient is that, we surveil these folks very closely for 5 years and then really for the rest of their life. So people describe a large amount of anxiety and anxiety surrounding the surveillance that goes on afterward, because in some cases they've lost a year of their life to this process, and it's so scary to think that it could be back, that we just want to make sure we support the patients through that and kind of understand where they're coming from. And then finally, just to summarize the key points, hopefully what we've learned here is prevention and early detection is key. We each have a role in that early detection and have a way of making that, improving that for our patients. We develop a systematic way to identify patients with worrisome symptoms, family history, or predisposing conditions like inflammatory bowel disease. And when we want to refer patients for endoscopic evaluation early, even when the patient downplays their own symptoms, and then finally provide support for patients in their survivorship both before and after treatment. Just a reminder, tomorrow starts Colorectal Cancer Awareness Month. I'll just open the floor up to any questions. if anybody's come up with anything.
And Dr. Groves, I did see that there is a question in the chat. I can read it if you'd like. The question is, if someone has some blood in their stool and thinks it's hemorrhoids, would that be a screening colonoscopy that they should receive, or diagnostic? Or
No, they can, yeah, they can get a diagnostic colonoscopy. So as soon as you see blood, you get to put them through for diagnostic. You'll get a fight with an insurance if you try to put it through as screening and they're not of a certain age. The other thing I forgot to mention is that when my patients come in, all my patients say, "Doc, my hemorrhoid's killing me," either from bleeding or pain. And I say, "Can you describe your symptoms to me without using the word hemorrhoid?" Because this word hemorrhoid, I mean, is like a self-diagnosis that they don't really know what it is. They've just heard the word thrown around so much. And I mean, I think oftentimes people have a hard time even describing something without using the word hemorrhoid. So you have to elicit, is it pain? Is it bleeding? That'll help you order your diagnostic colonoscopy. It'll help get it through, insurance properly, and it'll help you ultimately diagnose the patient properly, because they call everything a hemorrhoid. And I can't tell you how many anal cancers I've found that, they told the doctor they had a hemorrhoid and nobody thought to look or whatever it was. So I just tell them, describe your problem without using the word.
okay. And then there was a second part of that question asking if other types of modalities such as a FIT test, would that be an option at that point?
Yeah, I think depending upon obviously your access to colonoscopy, patient's resistance, I think it's a fair place to start. The FIT test is not quite as good as like a Cologuard or a DNA-based test. If you do FIT testing, you have to do that every year. But if it makes a more compelling argument for the patient to get a colonoscopy, or say that they don't need a colonoscopy, then the right modality is what they'll do. Cologuard is 92% effective in diagnosing or catching colon cancer, so it's not 100%. There are false positives with Cologuard, just like any other with FIT testing or anything else. But yeah, the right modality is what you can get the patient to do and what you can get them to do in a timely manner. Sometimes a positive Cologuard or a positive FIT test may get you an earlier colonoscopy too. So sometimes that's a great place to start. I apologize, my camera won't turn on. I think I'm asking too much of my computer right now.
That's okay. And just to clarify, so the stool-based test would be more if the patient was not having symptoms of bleeding?
I guess to clarify, just my recommendation is for colonoscopy because it's diagnostic and therapeutic. But if you're meeting a patient that says, "I'm not getting a colonoscopy, I have blood on my stool, but I don't want to get a colonoscopy," then that patient may require a little convincing. And that convincing may be this middle step of getting a FIT or getting a Cologuard. But I'd say at the end of the day, my recommendation would be for colonoscopy, just because it's diagnostic and therapeutic.
Okay, thank you. And if anyone else has questions, feel free to either put it in the chat or you can take yourself off of mute and ask your question directly.
Dr. Groves, you talked about how important early detection and prevention are, and with the screening age starting at 45, but we're seeing these younger patients and they're not exactly excited to talk about colorectal cancer. Have you seen methods or options or effective campaigns that reach this population at these ages to help them understand that they're still at risk and things to be watching for? I'm kind of thinking about it from the promotional communications side to complement this increasing population that we see now and that we potentially will see more in the future that may not be screening age eligible, but still need to know they need to be watching for these things. So I don't know if you've seen anything that you liked or had suggestions for us to think about.
I haven't seen any programs specifically aimed at the young person. I do think that, as mentioned, Chadwick Boseman, Trey Mancini, when they see, famous people that, they feel tied to in whatever way go through this, then it makes it somewhat more real for them, or people in their lives that have done it. And as it becomes more prevalent, unfortunately, we're all going to know somebody that's really young and had it. So we're in a transition time where, but the patients and the practitioners, in some ways don't recognize that this is a current issue. But I think this, in 5 years, we're all going to know a young person with colorectal cancer, and it'll be more convincing, unfortunately. So I have a case presentation. It's very brief, but it just kind of signifies exactly what we've been talking about. I saw a 42-year-old man in the emergency department. He came in with acute abdominal pain and distension. Initially said had noticed nothing out of the ordinary at all. But you know what? Actually, now that you mention it, for 2 months or so, I've noticed a little bit of a change in the caliber of my stool. I thought maybe I was just stressed out. I thought maybe, I just wasn't eating well because of the stress, and then had this 24 hours of severe pain. And now that you mention it, there may have been some blood in the stool here and there. No family history to speak of. This was actually a patient who had undergone medical school and a full residency, and still did not recognize these signs and symptoms, and gave me permission to talk about it. So because it's so in your face, and once it was diagnosed, they say, oh well, duh. But this was their CT scan in the emergency department. What you see here on the screen is the pelvis. Okay, so the white at the bottom of the screen, the bright white, is the sacrum. You get the pelvis on either side there, and then you have this classic apple core lesion, and this is the sigmoid colon. The rest of the sigmoid colon goes up and down, and then this is the rectum here, just in front of the sacrum. So this is a classic apple core lesion. I included this because this very large organ on the left side of the screen, right side of the patient, is the cecum. It's massively enlarged. It's about to explode. These can only get to about 12 centimeters or so before they have nowhere left to stretch. And then in the center of the picture, kind of toward the back, toward the spine, all these little lumpy things in here are lymph nodes. So presenting with, as a first quote unquote symptom, complete obstruction with lymph node involvement. And this is in an intelligent patient. So who's not afraid to talk about their stool. So this patient was diagnosed with stage 3 colon cancer, underwent a CT chest, abdomen, pelvis, and a CEA. The inpatient treatment for this was actually a diverting colostomy because they had such obvious nodal disease that was extending outside of what would be considered a normal resection area. They underwent the diverting colostomy, chemotherapy, and then finally surgery once they'd responded to some of the chemotherapy, and that will be followed by more chemotherapy afterward. But I think the important point is just that, that these folks are walking around until they're not.
Thank you. I had a question for you. You had said earlier that in younger patients, they tend to be diagnosed with a distal rather than proximal location of their colorectal cancer. Does that location, when, from the surgical standpoint and treatment, does that make a difference? Or do you see any differences in outcomes?
That's a good question. I think from a surgical standpoint, or at least from a patient standpoint, the further proximal the cancer is, the less at the end of all the treatment, at the end of all the surgery, the less the bowel movements will be affected. If you have a more distal tumor, obviously in the rectum, once the treatment is completed and the surgery is done, if you have a foreshortened rectum, you're at higher risk of incontinence and bowel changes. It's interesting, they don't really know why these tumors are more distal. There's no real guess for that, but it is a consistent trend over many studies. So one of the propositions from this was that perhaps we should change the screening to a flexible sigmoidoscopy. So that's like a partial colonoscopy that's a little less intrusive and less aggressive of a prep, because that's the thing that people hate the most, and do that at 35. So I think, in 10 or 20 years, that may be where we land. I don't know.
Thank you.
Mm-hmm.
Any other questions?
I have a survivorship related question. So post, and I know that these answers vary greatly, but post treatment, surgery, what does the long-term surveillance slash survivorship element look like for especially a young patient? I'm sure it depends on what they had done, but maybe just in general.
Yeah, just in general, your first 5 years out are going to be kind of your most intense time period of surveillance. So the first couple of years is every 3 to 6 months. You're getting a physical exam, a CT scan. If it's rectal cancer, you may get more studies than that. That starts to space out over time. The same is true of colonoscopy. So you get a colonoscopy a year after your initial diagnosis. If that goes well, then you can extend that out to 2 to 3 years. And then if that goes well, you can extend it out to 5 years. You'll never really get past the 5-year mark once you've had a cancer. If you have something like Lynch syndrome or a genetic marker that will increase your risk of future metachronous cancers, then you could end up getting a yearly colonoscopy. But for the most part, if it's just sporadic, and everything goes perfectly, then you'll be looking at scopes every 5 years.
Thank you. Any other questions? Okay, well, seeing that there are none, I did want to thank Dr. Groves for her presentation today and for addressing a lot of these questions. I will ask Andy to pull up. Our next session is going to be on March the 28th, and it will be on cancer screening guidelines and the importance of evidence-based early detection. Our April series is going to be on lung cancer biomarkers. We're still in the process of determining the May meeting. The June meeting will be cancer stress related to diagnosis and fear of recurrence. And then the July session will be around HPV vaccination. So you can register for those, follow the link. And also, we wanted to share with you, this will be in Charleston, but the Mountains of Hope Coalition and the West Virginia Program to Increase Colorectal Cancer Screening are sponsoring a cancer summit on health equity approaches in cancer screening. It will be on May 18th in Charleston. And so if any of you are in the Charleston area and could attend, we would love to have you at that meeting. So I do want to thank our speaker today and everyone for joining us. Once again, if this is your first time wanting to request CME credit for providers or for nursing credit, there Andy has a link in the chat where you would just register one time. So if you've already filled that out for us previously, you do not need to do it again for this session. So I do want to thank everyone. And Andy, I believe, will you be sending out copies of the slides? Okay. So Andy will send a follow-up email that will have share the resources that we shared with you, and then also Dr. Grove's slides from today. Thank you very much.
Thank you all.